Reflections on Nursing Practice is the topic of this special Nurses Week edition of the BRG Nurse Executive Podcast. My guest is Terry Foster, a well-known national speaker both in and for nursing, and was the first nurse to appear on TLC's Untold Stories of the ER series. Terry is without a doubt an uplifting and supportive nurse for any patient or colleague that interacts with him, and he used these talents during his most recently completed term as the 2023 president of the Emergency Nurses Association. Terry is a clinical nurse specialist at St. Elizabeth Healthcare in Northern Kentucky. So let's get started.
Welcome to the BRG Nurse Executive Podcast. BRG is a global consulting firm that helps organizations in disputes and investigations, corporate finance, and performance improvement and advisory. BRG's healthcare performance improvement practice offers multidisciplinary services to healthcare organizations. We focus on implementation with innovative, independent, and data-driven solutions. In the BRG Nurse Executive Podcast, we discuss improving patient care by advancing nursing leadership. For more information about BRG, please visit thinkbrg.com. Now here's your host, Nick Chmielewski.
Terry, thank you so much for joining us today.
Thank you. I appreciate it, Nick.
And happy Nurses Week.
Thank you. The same to you. And it is a week. It was a day many years ago, and now it's a whole week. Okay?
I know. May 6th to May 12th every year.
Yes. And one of those is Florence Nightingale's birthday. I don't know if it's the 6th or the 12th. And contrary to popular opinion, I did not work with her. Okay. So
I've heard that rumor. Appreciate you clarifying that. You've been around for quite some time. How long have you been practicing?
I graduated from nursing school in 1977, so I'm at about 47 years of being a nurse. So I just can't believe it when I say that. I can remember so much about graduating, being worried about taking care of a patient, knowing if somebody was really sick, what if a doctor would yell at me, all of those things that you're worried about. And when you start as a nurse, and I still remember that very well. And look how many years ago that's been. It's crazy.
And so our topic today is reflections on nursing practice. Before we think about where practice was when you started practicing and where it is today, why'd you go into nursing?
I was in high school, and my mother was actually an admitting clerk at the hospital. I'm one of 6 boys. And as the summer started, she said to me, in a very loving and motherly way, "You're not going to lay around the house all summer. You got to go do something." And I was 14, so I was kind of a little bit too young to get a job. I think I might have helped with papers or something like that. And she told me there were volunteers. They were called volunteens at the hospital. So I checked into it, and I had to take a bus to the American Red Cross in Cincinnati and learn like a home nursing course. I think it was like 2 Saturday mornings in a row. And I took that and became a Red Cross volunteer, and then applied at the hospital. And they said, we'll have you initially start out in transporting patients to physical therapy on Saturday mornings, which I did and I loved. And then they said something about somebody being a volunteer in the emergency department. And my mother, as I said, worked nights and I didn't drive. And so I was like 15, maybe around the time turning 16. My mom said, I'll take you down there and, drop you off and pick you up when I go home. And so they said, well, we've never had a volunteer want to work nights. And I was like, well, I think I want to do that. And I did it. And I was in love. I was in the ER, and there were, the fights and the drunks and the wrecks and all of that stuff and the saves. And I witnessed all that at a very, very young age. And I was like, this is what I want to do. And I thought I wanted to be a physician, but I saw how the nurses interacted with the patients very closely, and I saw truly their expertise, their assessment, moving of patients, dealing with families, dealing with doctors, things like that. And I thought this is a lot more achievable. As I said, I'm from a large family. I don't know that I could have afforded to go to medical school, and I'm not sure I wanted to be in school another 8 or 12 years upon graduation. So I think nursing school. So I thought this kind of is very attractive to me. So I applied at an LPN school, as I said, because finances were limited, and I was not accepted the first time into LPN school. And the reason was, the sentence was, your cumulative records were not supportive at this time. So what's that mean? And I made an appointment with the nursing director of the school and went down there. I was like, what can I do? Well, the reason I wasn't accepted is because they didn't have another guy in the class, so we could sort of practice on each other, giving baths, giving shots. So that's why I wasn't accepted into that class. She kind of leveled with me later on, but I knew, I was like, this is kind of different. So I got 6 months later, I was accepted. And that was in 1976. It was a hospital-based LPN program, Booth Hospital in Covington, Kentucky. And it was $425 to go to nurse LPN school. That was books and uniforms for a whole year.
That's like
So
a credit hour nowadays.
truly, it is. And I know this just sounds like it's in the dark ages, and maybe it was, but they used us, Nick, to staff the hospital. When you talk about advances, I mean, we were staffing, we were students, and we worked on the floors from, I think it was like 7:15 a.m. until 12:30, and then went over and had class from like 12:30 to 3:30, something like that, and then went home. And we did that almost every day that we were in school. I remember that very, very well. And so anyway, so I loved it. I was hooked, and then obviously I went to an RN diploma program in Cincinnati at Christ Hospital School of Nursing, and I remember other nurses said, don't go get your diploma, go get your bachelor's degree. And I knew exactly what they meant, and they meant it with very good advice. But I remember thinking, as an LPN at that time, the best nurses that I worked with were from hospital-based diploma schools, and there were a ton of them in our area. And I was like, that's the experience I want. And then I went back and got my bachelor's and my master's. And I think I took micro 3 times and chemistry 3 times, and use it every day, Nick. Okay, not really, but that's just what I had to do, to go back and do it. And I've not regretted one day becoming a nurse at all, ever.
You said earlier that you've been a nurse for 47 years, and a lot's changed in 47 years. And you kind of brought up the issue a little bit earlier about your ability to get into LPN school is that you were going to be the only guy in that class. And I think when I started nursing school 20 some plus years ago, I've been a nurse for 20 years now, I was one of 3 men in my class that I started in. So what's the difference been like being a man in nursing 47 years ago compared to now? There's certainly more of us now, but beyond that, what are some of the struggles or benefits that you encountered back then? And can you tie that to now?
Yeah, I would say I had a lot of people ask me if I was going to nursing school. Was I planning on going into anesthesia? No. Was I planning on going into administration? No. I don't know that people plan on going into administration, but I guess some do. But I think that was just because I was a guy. And then it seemed like the emergency department seemed to be a place where more males kind of gravitated towards, and maybe I was guilty of that. I'm not sure. I do remember, like, sometimes saying that they would say, "Oh, well, we've got lifting help here," or whatever. That may be a reason why I have a bad back today, because I was lifting help a lot. I'm only 5'8". I'm not a great big guy, but if I could help somebody or do that, that would be great. In my first position, I worked nights as an LPN, 150-bed community hospital. And my role in the morning, also during the night, if they ever had a male Foley that needed to be put in, I think I was the only male in the hospital, nursing wise. They would call me to go put them in, and that didn't really bother me. Like I don't, it didn't bother me. Go cast somebody and come right back. The other thing I had to do is any men in the hospital who were going for a barium enema, I did go up and give them their enemas, like start them at 5:30 in the morning. And I used to have like two or three going, and like I think about that, like why did they have me do that and stuff? Like why a female nurse couldn't do that, I don't know. I'm not bitter about it, but I remember thinking back then I just did what they told me. I didn't know any different to ask different or anything like that. I do feel like that there is some sexism, I guess, that occurred. And not that I'm whining about. I do remember in OB, I could only work labor and delivery as a student in the nursery. They didn't have any of the men on postpartum, I guess, for doing checks or massaging fundi or whatever. I assume, I don't really remember, but back then again, I just wanted to get through nursing school. I didn't want to take on, a big challenge. I just kind of did what they told me to. I did notice, and I have to say this a little bit more today still, I do think male physicians do pay a little more attention or whatever sometimes to the male nurses. And I'm not comfortable with that. I think it should be anybody, but I do notice that kind of dialogue a little bit more, or whatever. Maybe that's just camaraderie or something, but I sort of think, you're asking me and I'm not the nurse taking care of the patient. She is, like you should approach that person there. And I try to kind of channel that a little bit there as well. But for the most part, I've just not had any problems with, what some people go through and things like that. I do well remember they said if a doctor comes in the nurse's station back then, most all of them were male, stand up, give them your chair, get them a chart. Sometimes go get them a cup of coffee, and another thing, get them an ashtray, which, because a lot of them came in to the nurse's station smoking and stuff. And so I just did that. I don't know. It's just not being complacent on purpose, but just, it just worked out better for me to do that. I've never, ever felt like people treated me subserviently or differently as much because I was a male as a nurse. Years ago, periodically, if you'd have an intoxicated patient or whatever, I'd say something, they'd think I was the doctor and I'd say I'm the nurse. And they'd be like, well, what's wrong with you if you're the nurse? Well, nothing's wrong with me. And I'm not going to argue with you because you're impaired, and as you know, you have to have thick skin to work in the emergency department. And when patients are in pain or anxious or having a crisis, sometimes they say things to you. And I just don't get offended by things like that. I did have an interesting exchange, actually not too long ago, where I was trying to clean up this man that was drunk, and he had a laceration. He was, cursing at me, and he was like, "Get off me, doc." And I said, I'm not the doctor. I'm a nurse. And of course, he made some kind of remark. And the female ED physician walked in. She's kind of shorter and very pretty, very smart physician. And she walked in and he said, "Well, what am I supposed to call you, little lady?" And she goes, "You can call me doctor." And I was like, yes, like, good for you. The way she just said it, he was like, whoa, and stuff. I was like, yeah, things changed a little bit here. But for the most part, I have to say, been very, very limited for any challenges like that I have faced.
What are some other changes that you've seen in nursing practice from when you first started versus now?
How about if I just say everything and then we're done? Okay. No, I'm kidding.
Okay.
No, I don't want to be done. Honestly, everything has changed. And I mean, especially technology. And it's very frustrating to me sometimes how technology takes over the patient, and we are often consumed with figuring out the technology as opposed to figuring out what's wrong with the patient. I never want to lose the ability to know sick, Do I know if you're dying, if you're not dying, all the things to try to figure out. I never want to lose that ability, and I still have that. And I appreciate that technology that augments our decision making, whether it's AI, whether it's just data, whatever it is. I appreciate that. But nothing, I hope, will ever take the place of a really good clinician who knows sick, who has a wealth of experience and knowledge and education to put that all together and also make that person into a human being, and that's somebody's mother, father, grandmother, grandfather, to where we can, have that human connection there. It is frustrating to me sometimes and I do the same thing, when you see nurses nursing a computer, nursing a wow, and nursing the monitor, and there lays the patient. And I've been guilty of that. I remember, like, one time I said to a patient, I said, I got a lot of stuff to put in here, doing med rack and all that stuff. I said, let me know if you need anything. And I'm putting the stuff in, and I'm okay computer wise and stuff. And all of a sudden, like, I said, wait a minute, to the patient. I said, did you just say something to me a minute ago? He said, yeah, I said I felt like I was going to pass out, but go ahead, finish what you have to do. And
Oh
I'm
my
like,
goodness.
oh my gosh, I'm so sorry. He goes, no. He goes, I saw you were working, and he goes, I looked up and there's a heart monitor and there's oxygen. I'm laying down. He said, I thought, well, if I'm going to pass out, this is the best place to do it. It's like, I am so sorry, but like you have that tunnel vision,
Yeah.
and I was guilty. And so, he was okay. His vitals were fine and everything, but it is something where, I go up to our floors at, sometimes just to follow up on a patient or whatever. And if you look down any hospital hallway, you'll see 6 nurses working on a wow out in the hallway. And it's not that they're not doing their job. They're hitting all of the hard stops and the banners and all that kind of stuff. They're doing what needs to be done. But patients see them focusing on the computer, and sometimes not them. And I hate that part. My utopia is when a critical patient comes in, a trauma, a code, whatever, and a young nurse says to me, if you take care of the patient, I'll chart it all. I'm like, I truly have died and gone to heaven. This is the best scenario that I could work out, because I can say I got a 16 in their AC, I'm giving this, I'm giving that, and it's all charted. And that kind of marries that technology and experience. I do see changes for the good when I think about the things that we can identify and diagnose and things like that. I remember when I first started, both as a clerk and as a nurse, I just remember patients coming in just dying. We didn't know what was wrong with them, and we coded them or whatever, but we didn't know what happened. They just sort of up and died. It wasn't all that unusual, where today we can usually anticipate, and there's warning signs and data and things like that that we can identify, where I think when I first started, there were not a lot of that. We had a 20-bed emergency department and 2 heart monitors. And that was it. And we only put like an MI on a monitor or a code. I do remember sometimes having both monitors in use, and there was a code coming in, and I would go in the room and say, okay, you're doing a lot better. We can take you off this monitor. I don't know if the patient noticed I ripped that monitor off and rolled it out of the room real quickly and stuff, but that's all we had. And we had to use that. We had very little diagnostic equipment. Sometimes for a coronary care admission or an ICU admission, they would get the EKG on arrival to the unit. I remember seeing that order written, EKG on arrival to the unit. We x-rayed maybe 50% of our patients. A lot of times if somebody had a sprain, we would say stay off of it for the next day or two, and if it's still bothering you, come back and get an x-ray. I mean, now with defensive medicine and just all the advents of diagnostic stuff, it's just amazing. When I started as a nurse, we didn't have CAT scans. We did not have a CT scan.
Yeah, you're
Uh,
doing diagnostic peritoneal lavages, right?
oh, yes,
DPLs.
DPLs, we did those, and we diagnosed epidurals and subdurals and subarachnoids, hopefully on symptoms.
Wow.
And that was about it. And every once in a while, one of those epidurals got sent home and came back in and crashed and burned. And that's sort of how we learned that. And then when we did get CT for many years, it was on day shift. That was the only time. So, and now it's like, just do it at the drop of a hat.
Yeah, I mean, I've done, or not that I've personally done, but I've cared for a patient that had a DPL done while they were in the ED, one in my entire career, and it was very early on. And now, I mean, you bring it up, and people don't even know what you're talking about.
Nope, they don't. They really don't. And there's a lot of things. I've actually done a lecture on from Florence Nightingale to the Jetsons. And the craziest thing with that is people today go, "Who are the Jetsons?" Like, and the Jetsons are 60 years old, Nick.
Yeah, I mean, they're a little before my time, but I know who they are.
Exactly. So it was, but like I do a lot of things and they're just kind of retro. And I don't mean it like we had it so bad. I don't mean it like that, but just how it's all evolved and how much our practice, I have learned, has been adapted from military and wartime efforts. That's where mass trousers first came out. That's where the concept of triage very first came out. That's where open chest resuscitation very first occurred. All of those things. And, there's a lot of that stuff we don't do anymore. It's changed and improved over the years, but that's where a lot of that came from. And obviously the ENA is something I'm very much passionate about, but Judith Kelleher and Anita Dorr were both nurses during the war. Anita Dorr was a nurse in World War II. Judith Kelleher was the Korean War, but also both of them were nurses during the polio epidemic. And I looked up and read up a lot of things during our COVID pandemic about what they went through and what they learned about and stuff back then when there was no research-based, evidence-based practice, internet journals and things like that, getting information out, and they made it through. And so I think about that as like some of the changes that we have made and what we have seen. And now it's so rapid, the changes that come out. I mean, nurses can literally go on vacation and come back a week later. It's like, when did we start doing this? I mean, that's how quick stuff comes out and is implemented and evaluated. And you really got to keep up with that.
Yeah, I mean, but what sticks? I mean, because you hear so many stories in the EDs that I go to about it's a flavor of the week, it's a flavor of the month, it's a flavor of the charge nurse that's on duty. And if we're changing, are we changing because it's actually for the better? What does change look like? And how is change management operated? I think maybe is my question 47 years ago. And what does change management look like today in practice?
I think today in practice, anything that you have, I look at that as evidence-based practice that shows us good outcomes, how this is improved, how this can better our patients, but better my ability to deliver care as an RN. That's what's going to sell me. When it's the flavor of the month or the product of the month, or somebody said to do this or whatever, that's much more shady to me. But when it's something proven, documented outcomes, again, all those things that improve with patient care, I'm going to certainly buy into that. It's sort of like when I get a journal and, there's wonderful research articles. I don't read the whole article. I like to look at the abstract and especially the conclusions and kind of take away from that. And if it's something like, oh man, that would really be something, let me look at that and trying to take that back to practice, I think is something that if you can prove to a nurse that they have buy-in for that, how this works and can help them out, I think that's great. I can tell you that the emergency nurses that I know and I work with, we have an attention span of about 5 seconds. And unless you can get them and capture that and make it applicable to them, you've lost them. I also think it's a lot about your credibility, where if there's somebody who's come in I've never met before, I don't know what they're selling, doing, things like that, it's a lot different. But if this is a tried and true thing that somebody is convincing me of its worth and its benefit, and again, show me the evidence, that kind of stuff, I think that's the things. That is the thing that sticks a lot more. I can remember when HIPAA stuff first came out. I remember thinking, this isn't going to stick. This does not. Yeah, it's HIPAA.
Federal law's not going to stick.
Yeah, and honest to God, I was like, this is going to go by the wayside. Well, yeah, okay, not so much. I like to admit when I'm wrong sometimes, but I just thought, okay, everybody knows and all this stuff. It is kind of interesting how some of that works, because I'm amazed sometimes at the things that we do where there's no rationale for why we do this. When you say to somebody, why do you all do it this way? And they go, again, we've always done it like that, or whatever. And I've been at my institution a long time, and I will tell nurses I encounter, new nurses, I'll say, just because I say it's this way doesn't mean it's the best way or the only way. It's just the way I know how. And so I appreciate that information coming to me from an experienced nurse, one from someplace else. I'll give you a good example. During COVID, it wasn't the first round, but they called down and they had a patient bleeding out on one of the floors. So we had no ICU beds. They were trying to get an ICU bed. They said, can you take the level 1 fluid warmer up and show them how to use it? And I was like, yeah. I said, guys, I'm going to be gone a while. I got to go up there. And they're like, okay. And I don't know what was going on, but I was like, I'm going to be gone a while. So I go in, and there's this young nurse in there who actually is a friend of my daughter, Meredith. And they might have went to nursing school together. And she goes, Mr. Foster. Okay, that's your first clue. Okay. She goes, Mr. Foster. And I said, yeah, let me show you how to use this. And she goes, I just watched a YouTube video for how to use that. Can I show you what I learned and you make sure I do it okay? And I'm like, shut up. Are you kidding? I was like, well, yes, you smarty pants, you go right ahead. And by God, she put that thing together. I mean, boom, 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 and got it. And we got it going on the patient. And I'm like, my work here is done. You just schooled grandpa right here. And I went back down to ER, and they're like, did the patient die? And I was like, no, they have a really good young nurse who's taking care of them. And so I never thought about looking at a YouTube video to learn how to use a piece of equipment. And that was 3 or 4 years ago. Now I do it. Now, I mean, it's right there. And it was a reputable one, but there's also a really good homemade video on how to put an EJ in a hospital somebody did in Texas.
I've seen in some of the hospitals that I visit where the clinical educators will film their own videos and put QR codes on like low use items, like an intraosseous needle, or how to put on a reverse sugar tong or something of those natures. And you just scan the QR code, and either that's something that's been endorsed by your department, or it's your own educator telling you, hey, remember, this is how you use it, just in time training. How great is that?
I agree. And honestly, I embrace that technology. It's like that. Why reinvent the wheel? That makes perfect sense. And not everybody embraces that. And I just think that's okay, because we still have people say, well, they're using your cell phones at work. Well, everything is in your cell phone. Everything that you could possibly use is in your cell phone. Or need for calculations, looking up meds. I mean, all those things. I'm not offended by that. Yep, people might be on Facebook. Okay, I'm not the cell phone police, but to have that technology available like that is just, to me, it's just astounding. It really is.
Well, we've got a lot more to talk about, but I hope to have you back in a future episode. You are quite the comedian, and I look forward to talking to you about humor in nursing practice. Yeah, we can dig into that a little bit.
Never been told that. Never.
Any thoughts for our listeners as we wrap up this special Nurses Week episode?
Well, I would just say that I embrace the change that's gone on in nursing. I love every minute of it, but there still is nothing can be replaced by the expert care of a nurse. And I always point out to nurses, there's two special things that nurses have that I like to point out, and that is our use of critical thinking and our use of nursing intuition. And to have that skill, they're highly professional skills. That intuition where you say, I got a bad feeling about that guy. There's something going on with that guy we're not picking up on. Go with that feeling and be very proud of that. But also critical thinking. If I go into my huddle tomorrow at work and said, how to use critical thinking, they're going to say, I don't know, we had something in college. Why? Is there something we need to do that? Is there a CBL we need to do? Why? Did Joint Commission say we're not critically thinking? Is that a complaint? Okay, who said that? I mean, that would go like on fire. But if I said, I put an 80-year-old man in room 4 who had prostate surgery 2 days ago. He's confused and disoriented. See what's going on. And the nurse would go in and say, okay, is he having a TIA? Is he having a stroke? Is he an atrial fib? Is he septic? What are his lights? Let's get labs. Is he a sundowners? Did he take Vicodin? All those things, automatic critical thinking. We got that. Be very, very proud of those two skills as a nurse, because that comes with experience that can never, ever be replaced.
Terry Foster, happy Nurses Week to you and all our listeners. Thank you so much for joining me. Appreciate it.
Thank you, Nick.
You've been listening to the BRG Nurse Executive Podcast, which focuses on improving patient care by advancing nursing leadership. The views and opinions expressed in this podcast are those of the host and podcast guest and do not necessarily reflect the opinions, position, or policy of the guest employer, Berkeley Research Group, or their other respective employees and affiliates.